Welcome to Forum 360. I'm your host, Leah Love, where we have a global outlook from a local view. Today, I am so excited. We have Dr. Rajdev here with us today, and he is going to talk about the latest advancements in medicine. Thank you for joining us today.
Thank you so much for having me. Yeah.
So tell us a little bit about your background and where you work at.
So I am an interventional radiologist. Interventional radiology is a medical subspecialty where we perform minimally invasive procedures using things like X-rays, ultrasound, and CT scans. So, using those imaging techniques, we're able to do procedures in a kind of non-surgical, minimally invasive fashion.
Perfect. All right, so what is the interventional radiology and how are these procedures performed? I know you just gave us a little bit, but can you give a little bit more?
So, the procedures that we do at our facility are all kind of outpatient-based procedures. So a patient comes in, they have their consultation, and then we bring them back to a room and where we use a combination of ultrasound and X-rays to perform procedures inside of the blood vessels.
Okay.
We use X-ray dyes and inject the dye and then look at the dye under X-ray guidance, and that helps us to guide our procedures, whether it be to treat those blood vessels by kind of opening them up or maybe closing down some abnormal blood vessels.
Okay, and what procedures are typically would use this?
So the general type of term, the medical term is called embolization.
Okay.
Embolization is a medical term that just means a focused shutting down of targeted blood vessels.
Okay.
And those targeted blood vessels may be causing abnormalities in certain organs or may be causing patient bleeding and other types of symptoms.
Perfect. So what is knee osteoarthritis and what types of symptoms do patients experience?
So osteoarthritis is a common condition that affects the joints.
Okay.
It's basically has to do with inflammation inside of those joints. The most common joint that's affected is the knee.
Okay.
So as we get older and as we use our joints, the cartilage inside of the joint starts to break down. As that cartilage breaks down, it releases chemicals, and these chemicals and these enzymes lead to basically a vicious cycle whereby there's further cartilage breakdown and inflammation. That inflammation can be a source of severe pain. And when patients develop debilitating pain related to osteoarthritis, knee pain, it can really present a challenge for them in their mobility, in their ability to kind of do their activities of daily living, and kind of affects their entire life. It typically comes on at around the 5th or 6th decade of life. So as we continue to kind of use our joints, the osteoarthritis sets in.
Mm-hmm. And what's the typical plan of treatment as opposed to kind of what you offer?
Sure. So, if we kind of look at the landscape of how this condition is treated, it starts off with conservative medical therapy. So these patients are seen by their internal medicine physicians, their family practice physicians, and then they may be referred to things like physical therapy. Exercise and weight loss can help a lot because we know that as you put on more weight, there's more pressure on those joints. Mm-hmm. So these sorts of things are kind of the earliest stages of what we would do in the conservative therapy. In some patients, they may require to be taking medicines like ibuprofen or Tylenol. These are anti-inflammatory, non-steroidal anti-inflammatory medicines, NSAIDs. And then in severe cases, sometimes they do end up getting on stronger pain medicines. That's sort of the first step. After that, patients may be eligible for things like joint injections, which are very, very common in the United States. Mm-hmm. The types of injections they might be getting is injection of things like corticosteroids. Mm-hmm. So steroids reduce inflammation, and they're injected directly into the joint. Mm-hmm. There are also newer things that you can inject into the joint, like gel, which helps to cushion the joint, as well as other newer things like stem cells and something called PRP. So that's kind of the initial progression of how we kind of treat things. Now, on the complete opposite side of the spectrum would be something like knee replacement. Okay. So knee replacement has been around for a long time. We know it works. It's a very effective therapy, but it's typically reserved for patients who are in the most severe stages of osteoarthritis. And you have to it is considered a major surgery, so one would have to be relatively fit medically in order to undergo this type of surgery. Okay. Now, for patients who have maybe tried joint injections and physical therapy, but maybe don't qualify for a knee replacement or maybe don't want a big surgery yet, there is sort of this in-between territory, and that's where this new therapy that we're going to talk about kind of fits into that, called geniculate artery embolization.
Okay. So tell us more about that.
So embolization, again, is shutting down, targeted shutting down of blood vessels. So when we enter into this inflammatory cascade, this cycle, where you get breakdown of cartilage, release of inflammatory enzymes, this sort of leads to a continual breakdown and a cycle that just kind of goes on ongoing until you can find a way to kind of reduce that cycle. As part of inflammation, you get the growth of new blood vessels. These blood vessels are abnormal, are not meant to be there in your body, and basically contribute to this release of these inflammatory enzymes and this whole cascade. With genicular artery embolization, we target these blood vessels, these abnormal blood vessels specifically in the knee, and embolize them or shut them down. And that breaks the cycle and can lead to pain relief within days to weeks and sustained pain relief for years.
And you said this would come before a knee replacement, kind of like in that middle area.
Exactly, in that middle area. Patient who has tried conservative therapies that have not worked, and prior to them getting a knee replacement.
Are there things that would rule them out? Contraindications, anything like that would rule them out for this?
There are, just a few. Right now, the type of inflammation that we're treating is mainly in patients who have, again, osteoarthritic type of inflammation.
Okay.
Now, if you have inflammation in your joints related to something that's not necessarily related to wear and tear, but things like autoimmune.
Okay.
For example, rheumatoid arthritis would be an example of that. This is an autoimmune condition that affects the joints. This would not be somebody who would be indicated to have this type of procedure.
Okay.
Another contraindication would be somebody who maybe has an active infection in their joint.
Okay.
Again, their pain is most likely related to inflammation, related to infection, rather than, again, wear and tear.
Okay.
So they would need a different type of therapy.
Perfect. What's the success rate of this?
So when we talk about success rate, the first thing that the patients want to know is what's the clinical success rate? I get a procedure done, and am I going to feel better? So, looking at all of the available research and data, we quote to our patients about a greater than 85% success rate, so fairly high.
Okay.
I can tell you anecdotally, our patients do very, very well. The other thing to look at is whenever you're having any type of medical procedure or any type of surgery done, you want to know what's the technical success rate. If I actually end up on the table, are they going to be, successful in doing the procedure? That is close to 100%. So it is a very kind of technically straightforward and type of procedure that we're able to do successfully in almost every single patient.
Awesome. Amazing. Yeah. What's the downtime?
So, our patients get, up and they're walking immediately after the procedure. A few days of maybe some soreness and, related to just, where we've kind of gone into the artery and what we're treating is normal. But it's really just a few days of downtime.
And how long has this been around that you've been performing this procedure, or that it's been
studies? So in the United States, this procedure has actually been performed at major academic medical centers for the last 5 to 7 years.
Okay.
Now, whenever there's a new procedure, there's always a lead-up time. Clinical trials take place in these bigger centers, the data gets published, and then it gets more widespread and much more common. And we are now at the point at which this is much more common in the United States.
Perfect. And you said there's not, the risk is a lot more minimal than with a traditional surgery after?
Absolutely. Yeah. So our downtime is a lot less, and also the complications of this procedure are very, very minimal. Patients can expect a little bit of bruising around the knee after the procedure, but the risk of any kind of serious complication is less than 1% and really not related to kind of what we do.
Now, is this something that's considered cosmetic, or is it covered by insurance?
It is covered by insurance, and we work with patients, their individual insurance carrier, to get pre-authorization,
okay,
to make sure that they are covered. If there are any out-of-pocket costs, we make sure that we disclose that before we move forward with anything.
Perfect. So I wanted to talk about another type of embolization, okay, which is uterine fibroid embolization.
Yes.
So give me the broad overview of what that is.
So again, we're talking about a type of embolization, so we're talking about shutting down blood vessels. Mm-hmm. But here we're talking about a completely different disease process, fibroids, mm-hmm, uterine fibroids. Uterine fibroids are benign tumors that can grow inside of the muscle of the uterus. These tumors, although they are benign, start growing as soon as women hit puberty. They're driven by hormones. So from the moment you hit puberty until you complete menopause, these benign tumors are slowly growing in your body. And many patients have them, and about 60% of women will actually have fibroids. A subset of those patients will be very symptomatic from having those benign tumors, and it has to do with the location of the tumor, where it's located in the uterus, and also how it's growing off of the uterus. In those settings, it can cause symptoms of severe bleeding. We call that menorrhagia. And it can also cause symptoms that are a little bit more vague and hard to pinpoint based on their location. For example, if the fibroid is growing, and pushing upon the bladder, that can cause symptoms of urinary frequency and urgency. If the fibroid is growing in a particular direction, causing obstruction of the bowels, it can cause things like chronic constipation. So there's a myriad of symptoms that are related to uterine fibroids, but the most common one being heavy menstrual bleeding.
Okay. Is there anything that increases them, like as far as health, diet, your gender, your race? Well, not your gender, but your race, your background, demographics?
I would say the one thing that we have studied is it is more common in African American women. So that is true. And the only other risk factor is, fibroid does have a genetic component. Mm-hmm. So many women will say, well, my mother had hysterectomy or had other type of surgery on their uterus in the past for heavy menstrual bleeding. Mm-hmm. And that's fairly common. That's fairly typical of what we'll see.
Okay. So what is your pain management plan, and how do you come up with that for your clients?
So anytime we do any type of procedure, especially whether it's a surgery or anything, we always want to think about what their pain management would be afterwards. With this particular procedure, because we're shutting down blood flow to a muscular organ, to a tumor, there can be some pain after the procedure. Okay. That pain is actually caused by inflammation that develops inside of the fibroid after we treat it. Okay. And so the pain regimen that I put patients on is very much targeted and focused towards anti-inflammatory medicines. Okay. So we put the patient on a schedule of 2 different types of anti-inflammatory medicines one is a prescription strength NSAID. So it works kind of like ibuprofen. Think of it as like a prescription strength ibuprofen. Mm-hmm. And they'll take that along with Tylenol for basically a period of 3 days, and then switch over to things like Motrin. Okay. I do give them a short course of narcotic pain medicine for any type of breakthrough pain, but I will say that this is pretty unusual that they would have to actually take that. The anti-inflammatory medicines that we give are pretty strong and help control the pain afterwards. The inflammation you get after a procedure like this peaks at around 3 days. Okay. After 3 days, that inflammation will subside, and that's one thing I always.
Is there any reason why it's 3 days?
It's just, it's just something that we see in our patients, okay. Yeah. But it sort of peaks around there, and then it'll kind of hit a trough. Other things that can cause pain after a procedure, doesn't matter what type of procedure, is constipation. So we always make sure that our patients have good bowel movements during this whole time.
Okay. Yeah. And if you are just tuning in, we are talking to Dr. Rajdev about the latest advancements in medicine. So getting back to talking about fibroids, what is the process of the uterine fibroid embolization? What can they expect when they come in, when they go out, all of that?
So it's a similar thing to the genicular artery embolization in the sense that they'll come to our center, we'll meet the patient, do a consultation, review their entire medical history, and that includes any prior pap smears that they might have had, any prior endometrial biopsies that they might have had. We want to make sure that this is the right procedure for the right patient. Okay. Once they kind of meet the criteria...
Wait, pause.
Yep.
Okay, so who would it not be good for?
So in a patient who has postmenopausal bleeding, okay, I would want to make sure that they have a lot more workup done, okay, especially in somebody who's in their kind of mid to later 50s. Now, menopause hits everybody at a different age. And so they may still be premenopausal or perimenopausal, but having severe symptoms related to their fibroids. I would want to kind of prove that that's all been done. Okay. One of the additional steps that we might take is to get something called an MRI, okay, which is an advanced imaging, cross-sectional imaging technique that we can do, specifically looking at the uterus and to make sure that there isn't anything else going on. After menopause, having bleeding may be an indication that there's something else going on, okay, such as malignancy. Okay. And those would be something that we would want to rule out prior to moving forward with any type of procedure.
Okay. Yeah. All right. So then the rest of the procedure.
Right. So they've met all the criteria. Okay. I evaluate them. I decide this is a great candidate. This procedure is actually done by entering access into their blood vessel through a blood vessel in the wrist. Okay. So we're able to kind of get access into the blood vessel in the wrist, travel down into the blood vessels of the uterus, and once we identify the uterine artery, we'll place a very small, what we call a catheter, which is nothing but a very, very small straw hollow straw that kind of goes into the artery, after which we will inject our embolic agent, which is basically very small microscopic beads that go in and block off the uterine artery.
Okay. So typically, I had a laparoscopic myomectomy.
Okay.
And I believe that's an option, a hysterectomy is an option, and
Yes.
this is an option. What would be the difference of why one would choose? Because I know there's so many options, and you're trying to figure out which one is best for you, especially if you don't want to get a hysterectomy.
Yeah.
So what would be those reasonings why you would?
So, you broke it down really nicely. In terms of surgical and non-surgical, in surgical we have hysterectomy, which means completely remove the uterus.
Okay.
Myomectomy, which you mentioned, is a surgery, again, where the surgeons, the gynecologists will go in and sort of pluck out the fibroids that are there. This is also kind of very effective, but it is a surgery. In terms of a non-surgical option for fibroids, uterine fibroid embolization is really kind of one of the main non-surgical therapies that we have. So if we're going to compare sort of, two different ones, I would want to compare fibroid embolization versus myomectomy. And the reason for that is because both of them are uterus preserving kind of surgeries. Okay. That means that you keep your uterus, that means that you keep your fertility if you want to. And if you look at the quality outcomes between the two, there was actually a large study that was composed and written up in the New England Journal, a trial called the FEM trial, where they were trying to look at what are the quality of life outcome differences between these two therapies. And what they found was that both were very effective in treating patients' symptoms and improving their quality of life between the two. So both are, very, very effective therapies.
And how long has uterine embolization been around?
It's actually been around since the 90s. I know that a lot of patients come to me and they're surprised. They think it's sort of like a new, brand new kind of technique or procedure, but no, it's actually been around for decades.
Okay.
It's just that the prevalence of information regarding this procedure and, what we're able to kind of share with patients, that part on the patient education side has maybe been lacking.
So what would you suggest, let's say there's a young doctor who's watching you and wants to get into this area. What would you suggest for them to do?
Absolutely. Well, I think it's all about outreach. At our center and our group, Preferred Vascular Group, we really do our best to kind of get out there, meet with people in the community, meet with physicians to let them know that not only does this procedure exist, but it's done completely in an outpatient setting, and it's available in your community. We're not affiliated with a large academic center, and we really try and target the community that we're in Mineral Falls and the Akron Stowe area. And so that's what I would recommend, is just kind of getting out there and doing as much education as you can.
Perfect. You did mention about fertility.
Yes.
Can you tell me about the impacts on fertility?
So this is sort of one of these kind of controversial areas where initially, we were trying to study this and try and figure out, what's the effect of fertility between a surgery like myomectomy versus a fibroid embolization. And I can tell you, based on all of the available research, all of the available kind of data that we have, there really is no difference in the effect on fertility between these two surgeries. Fibroids themselves can affect fertility.
Okay.
If a fibroid is obstructing a fallopian tube, if a fibroid is affecting the uterine lining, just having a fibroid itself can lead to infertility. If you treat that fibroid, whether it's through myomectomy or if it's through fibroid embolization, you can actually improve the patient's fertility.
Okay.
So, that is one of those things that, if just looking at what we have available to us, there really is no difference. I will say this is a hard question to answer. It's a hard question to study. And the reason for that, it would be hard to do a randomized controlled trial. It just wouldn't be one of those things that would be easily accomplishable. The other thing to think about, too, is many of these patients that we see, the vast majority of them are family complete, as we would say, which means that they've either had kids or are no longer even, considering having future kids. So it's hard to, look at that. We have done studies looking at something called the anti-Mullerian hormone. That is a hormone that helps to produce follicles in the ovary. And you need follicles to produce eggs, which would, again, be involved with the whole process of fertility and having a child. There is no change in this hormone after you get a fibroid embolization. So the ovarian function remains.
Okay. So after the procedure, how long, I know with my myomectomy, they said that the fibroids could grow back again next year, essentially. What about with the embolization? Is there a longer?
Although they may kind of grow back, it's much less likely with the fibroid embolization, which is why it is a great therapy for somebody who is younger in age.
Okay.
When you're doing a myomectomy, you're relying on the ability to identify, either through palpation, through correlation with imaging findings, that you're going to be able to actually physically find the fibroid so you can remove it. But there may be fibroids that are in there that you can't see or on imaging and you can't feel. So those small little bits of fibroid tissue, those benign tumors, will remain, and they will continue to grow so long as you're premenopausal. Fibroid embolization is nice because it doesn't, it hits everything, basically. Any, fibroids that are present, it doesn't matter how many of them are, the embolization technique will affect all of them. So when that's with one procedure. So you're much less likely to kind of, down the road, develop a new, larger fibroid. Yeah.
It's just amazing, the advancements.
And you get to leave with a Band-Aid on the wrist,
Right,
as opposed to, major surgery where you're kind of waking up and you're under anesthesia. We do
Yeah.
everything. These are awake procedures. So
Okay.
they're just done with moderate sedation.
Okay.
And then you kind of walk out, you got a Band-Aid on the wrist, and that's about it.
It's amazing. So in talking about being your own advocate, what are the questions that people can go and ask for both of these embolizations?
Absolutely.
What should they make sure they ask their doctor about?
So I think if you're somebody who's suffering from chronic knee pain and you've tried physical therapy, you've been on medicines before, you've tried joint injections, this is another option for you. You can find more information kind of on our website. And you can ask your doctor about this procedure and have them, kind of reach out to us and send us a referral, and we'll be happy to see any patient. Same thing too with uterine fibroid embolization. Many of these patients have been seeing their gynecologist. The initial therapy is always medical therapy. It's always a non-procedural type of therapy for fibroids, and that may include oral contraceptive pills or something called tranexamic acid. These various different types of medicines that can help control symptoms of bleeding, for example. And ask them about fibroid embolization. There's a lot of great information out there on both of these procedures on the internet, and even our website can provide you with a lot of that as well.
Perfect. You said there are no side effects really with the uterine embolization.
Every procedure we do, does have complications that we'll discuss with the patient and things. With fibroid embolization, the main thing that we talk about with patients is the pain afterwards. We want to make sure that that's under control and that we have come up with a good plan and set expectations. There are things that are a lot more rare, but we're always talking about patients about potentially developing an infection, potentially developing some other complication that would require them to get a hysterectomy. These are very, very uncommon, but can always be present.
Okay, perfect. And is there anything else you would like to share about these as far as information we didn't talk about?
Absolutely. Well, I think the biggest thing is that, so our center is located in Monroe Falls. We actually have two other centers in Northeast Ohio, one in the Beechwood area, it's called Cleveland East Vascular Care, and one on the west side of Cleveland, Cleveland West Vascular Care. These are all part of our preferred vascular group in Northeast Ohio. And at all of these centers, we perform these procedures. So if somebody lives closer to the west side of Cleveland or maybe on the east side, they can find out more information. And the medical directors there are both interventional radiologists, Dr. Eric McCloney and Dr. Dan Rocky. Both of them have a ton of experience under the belt and can perform these procedures.
Perfect. Okay, so in our last little bit of time left, tell us a little bit about how you got drawn into the medical field.
I'm lucky. I had an aunt who was a physician. She's a vascular surgeon, and she worked a lot with dialysis patients doing fistula creation. And so I kind of just grew up with her, and she and I have an older sister. She and I were both kind of drawn to medicine from an early age, and just seeing my aunt work and seeing the patients that she was really affecting their lives, changing their lives. So my sister became a surgeon, and then I decided also go into medicine. And so it's interesting because they always wanted me to kind of go into the surgical subspecialty, but I kind of had my own path here. But it all kind of comes full circle, yeah.
And do you have any feel-good stories of any success patients that come to mind?
We did a geniculate artery embolization recently on a patient, and it was amazing. She went from not being able to do the kind of things that she really wanted to do, which was, things like hiking, yoga, and, we saw her for a 1-month follow-up recently, and she said no pain. In the areas that we treated, there was no pain, and it really feels good. It really feels good to be able to change somebody's life. These are patients who may be of retirement age or getting close to retirement, and they're looking to basically, take back control of their life and enjoy the time that they had. They worked so hard their whole life. Many of these patients, maybe were runners or joggers and want to get back into it. Having debilitating knee pain can really, really change your life, really affect your life. So if I can fix that, if I can take care of that, it's very rewarding. It really is.
I bet it is amazing to be able to see those changes and transformations in people. Well, thank you so much for joining us today. We want to again remind you guys how you can contact Dr. Rajdev, listed below. And if you are in need of any of these services or just more information about these advancements in medicine, be sure to contact them. I am your host, Leah Love, where we have a global outlook from a local view, and I hope you have a wonderful rest of your week. Thank you.
Forum 360 is brought to you by John S. and James L. Knight Foundation, the Akron Community Foundation, Hudson Community Television, the Rubber City Radio Group, Shaw Jewish Community Center of Akron, Blue Green, Electric Impulse Communications, and Forum 360 supporters.